surgical resection sometimes may be impossible. Radiotherapy, especially modern radiotherapy techniques, including heavy particles, may offer important advantages. So it's my pleasure to introduce Dr. Fiore.
Thank you.
Focus on non-sarcoma proton therapy and carbon ion radiotherapy.
Okay, thank you for inviting me and giving me the possibility to talk about the role of proton and carbon ion radiotherapy in bone sarcoma. I will talk about the, sorry, just not to change this slide, this one. Aspetta. Forse lì dici? Sì, okay, okay, sorry. I will talk about the scientific base to use using carbon and protons and carbon ions, their role in the therapeutic strategies for bone sarcoma, and some clinical application by some example of treatment by site and histologies. So, proton and carbon ions radiotherapy. Can you hear me without? Okay. I'm sorry. Okay, so proton and carbon ions, also called particle or EV ions or hadron therapy, aroused a very great interest in clinical application in the last decades, thanks to their physical and radiobiological properties. What about physical properties? The physical properties are in common to protons and carbon ions. So you can see in this picture the behavior of the releasing dose of proton and carbon ions, very low dose in the entry tissue, and the maximum releasing dose in a definitive, precise point in the depth where the tumor site is. The different behavior from X-ray releasing high dose in the entry of the tissue. This is a behavior of a single particle, an example of a single particle in a regular tumor shape. So accelerating more particle, we can have a beam covering all the tumor volume in their precise site in depth. So you see the beam, particle beam with high dose on the tumor, low dose on the entry tissue. And the most important thing is the stop dose at the end of their pathway. So these properties give us a very important clinical advantages, that is distribution dose, sparing healthy tissue, and we hope very less side effects, so very low toxicity. You can see in this picture one of the first dosimetric study comparing a plan with photon therapy and proton therapy. So you see the low dose around the tumor in the proton plan are very, very low. Then the photon therapy plan with the IMRT, that is one of the most precise radiotherapy treatment plan, radiotherapy technique. So you see the eye are completely, almost completely spared, the bone, the bowel, kidney, and spinal cord, and healthy brain tissue. The technology is helping us to improve these advantages, and you can see these technologies is active scanning in our we have a beam with active scanning, giving us the possibility to create different dose distribution into the same volume, target volume. You can see this the example of sparing selective nerve roots in the same tumor volume. Radiobiological properties is a typical characteristic of carbon ions, and it is very important for radioresistant tumor, so the majority of sarcoma patients, sarcoma tumors, particularly for bone sarcoma. Radiobiological property consisting in giving multiple damages in a short distance of DNA, and this distance is calculated less than the diameter of DNA. So you can see the difference in multiple damages and in between EV ions, so carbon ions, then X-ray. These properties strongly reduce the repair mechanism of tumor cell. This is a funny example, so you can see it's easier to repair damages like that rather than multiple damages like that. So but we have to take into account that there are bone tumor, bone sarcoma, very, very radioresistant as osteosarcoma, high-grade chondrosarcoma. So we have to consider that we can have some reparation, so recurrence even when we treat with carbon ions, of course. But in a best case, we have some results like that. This is a typical big sacral chordoma, recognized as one of the most radioresistant tumor. And after 1 year of carbon ion treatment, we starting to see impressive reduction of the mass. When we can use particle therapy, proton and carbon ions for all tumors close to organ at risk, or critical organs, critical anatomical region, where it is important do not exceed to the dose of healthy tissue, to not overcome to the dose constraint of critical organ. The same for ray radiation, where it is important to do not exceed to the dose to the healthy tissue, to the tissue already irradiated, particularly carbon ions for radioresistant tumor. So sarcoma respond to all these characteristics. So which is the role in therapeutic strategies for bone sarcoma? Of course, the most frequent bone sarcoma we already saw in the other presentation: chordoma, chondrosarcoma, osteosarcoma, recognized as a radioresistant tumor. So carbon ions are very particularly indicated for this tumor. Ewing sarcoma is well known as a radiosensitive tumor. Protons are indicated for Ewing sarcoma. Particularly when? First of all, it is important to say that every indication for sarcoma has to be discussed in a multidisciplinary approach. It's very important because they are rare tumor, very difficult to treat, so multidisciplinary expertise team is important. Generally, surgery remains the main choice for all sarcoma. Chemotherapy, the indication to chemotherapy is based on the histologist, but focused on particle therapy. We can consider proton therapy in adjuvant setting after surgery with positive or close margins. High dose of protons or carbon ions based on the histologist when we have macroscopical residual after surgery, or when the tumor are considered not unresectable because of large mass, because of more critical structures are involved, and when disabling surgery is considered. Sometimes some patients, as we already discussed, they refuse disabling surgery. So the indication is recognized in European guideline. This is European ESMO 2021, where all of three, they recommend heavy particles should be considered for all of three radioresistant histologies, mainly for unresectable tumor. In NCCN guideline, so in American guideline as well, we see recommendation with protons, carbon ions, or other EV ions. So some clinical application. When we have, I'd like to point out that even despite the potentiality of carbon ions radiotherapy, from 1994, when unresectable tumor, in Japanese center, they started to treat unresectable bone tumor. To date, we still have few data about carbon ions treatment because of the rarity of the histologies, but also for the few centers are available. This is the most recent list from Particle Therapy Cooperative Group. You can see we have only 14 carbon ions facilities in clinical operation versus more than 100 proton facilities in clinical operation. And I want to point out then that from 2009 we started to have more facility with carbon ions beam. We started in 2012. This is our center, CNAO in Pavia. Is a dual center having a proton and carbon ion beam with active scanning. This is our synchrotron, the big machine in 29 diameter, where this we starting to accelerating beam, choosing proton on carbon ions from this source, accelerating, and the beam is direct in 3 rooms. These are our tour of our 3 rooms. Okay, we started in 2011. We treated almost 5,000 patients. Among the sarcoma patients, we treated the 89% were bone sarcoma, and in our center, the carbon ions is the main choice for sarcoma. According to the guideline, we treat unresectable macroscopical residual, recurrence after surgery, or re-irradiation, so recurrence of patient already irradiated. In adjuvant setting for bone sarcoma, the indication must be discussed because we treat the patient we treat patient with R1 only for patient with a particular critical anatomic region as head and neck osteosarcoma. So these are an example of treatment by site. In skull base, the most frequent histologies are chordoma and low-grade chondrosarcoma. For historically, the adjuvant radiotherapy is recommended, and historically particle therapy has been used because in this region we need the physical selectivity of proton or carbon ions to spare the organ at risk very close to the tumor, optic pathway or brainstem, so very important organ. Is different the head and neck osteosarcoma and high-grade chondrosarcoma, less frequent histologies, more aggressive behavior, and we find that because of the delay in diagnosis, often we find a large mass, so it's difficult to achieve adequate oncological margin. In this case, we prefer to use carbon ions. This is a case treated in recurrence in osteosarcoma recurrence in a young lady. She had in pediatric age Ewing sarcoma, treated by chemotherapy, surgery, and concomitant chemoradiotherapy. After 15 years, she developed an osteosarcoma, again treated with chemotherapy, surgery, and chemotherapy. After 2 years, again, large local recurrence, and we treat her with you see the largest extension of the tumor. This is a plan with carbon ions. We spared completely the contralateral eye, but of course it was not possible to spare the eye on the same side of the tumor. This is the baseline MRI, and the last follow-up in February, you can see an impressive reduction of the mass, even if we have to consider the necrosis in the treated area. So, of course, we can have important side effect even with carbon ions if the mass is big and the anatomic region is critical. Spine chordoma and chondrosarcoma. The unblocked resection is okay, sorry, okay, I accelerate. Spine sarcoma and chondrosarcoma, unblocked resection give the best results, but the results are improved with adjuvant radiotherapy with high doses. So you see the critical region. So in this case too, is important to have selectivity. Quickly, this case is a vertebral chordoma. This patient refused the surgery, and we treated with carbon ions after a long discussion with the patient, because sometimes the patients want to refuse the disabling surgery, but it's our duty to explain very well which is the best choice for him. In this case, if patients refuse, we cannot say anything. So, sorry, the recurrence next to the spinal cord after 20 months. Even the big mass is, we see a reduction. This is another case of chordoma. Pelvic chordoma chondrosarcoma has a poor prognosis than the other side, because we find a very big mass. So this is important, the role of radiotherapy, of carbon ions radiotherapy, above all in patients with unresectable tumor. This is a good example of good results. After 3 years of this is the baseline MRI. After 3 years, we saw a very good reduction of the mass. Sacral chordoma, one of the most recognized indication for EV particle, and because the damages from surgery depends on the level of the extension of the tumor, and in this case we starting to have the choice of patient. You see, in this case, when the tumor is from S2 level, we have the possibility to discuss with the patient, and the patient preference to choose carbon ions. So this is an example of good results after 2 years, the big mass and reduced mass. I prefer to conclude because I know I'm sorry. So in conclusion, the role of particle therapy, I think, is clear for radioresistant tumor difficult to treat because of the volume and the critical region, anatomic region, and maybe could be an alternative for patients refusing disabling surgery. Multidisciplinary discussion is absolutely mandatory. Thank you. Sorry for the delay.
Sorry.
yes.
You can.
Yes, we can for all patients and from foreign patient too.
Right. Okay.
Sì.
So
Sì.
you're coming from other places in Europe.
Yes, 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 of course. We have some systems, on our website. You can find every contact for internet. We have an international patient desk and Italian patient desk.
We're building 3 now in Norway, so
Yeah,
in
in the
January next year.
proton therapy. Yes.
Yeah, they will not come to Italy. So
Okay. Yeah.
thank you.
Thank you.
Hi, thanks very much. Can I ask a question about the Ewing sarcoma, which
Yeah.
you said are responsive to radiotherapy?
Yeah. Yes.
So
Okay.
would you recommend, as a procedure, radiotherapy pre-surgery or post-surgery for treatment of Ewing sarcoma?
Okay. No, Ewing sarcoma is
So this is a different
it's a big
scenario,
question.
yeah.
Big question. It's a different scenario. Okay, no, I think Ewing's, I didn't mention Ewing sarcoma because, as you can see, our experience in bone sarcoma is most of with carbon ions, and because Ewing sarcoma is correct to be treated and involved in international protocol. This is our our approach to treat if some particular histologies are followed, has to be followed in a center. But to answer your question, we treated some Ewing sarcoma when surgery is not possible. That's it. Not in pre-operative, not in post-operative. We treat only patients where the surgery is not possible because it's a curative treatment, recognize the curative treatment, so it is right to follow the recognized curative treatment.
So I asked the question because depending on who you discuss this strategy with and which clinical trial you talk to, whether you should try to shrink the tumour before surgery or you should perform surgery and then use the radiotherapy to try and mop up residual tumour. I think this is still an important question in Ewing's. Anita's going to answer it for me.
No, I'm not gonna answering this, and I know that there are different philosophies about that, and there are centers where also the surgeons like pre-operative radiotherapy, other centers dislike. I come from a center where they dislike it, but I think an argument not to do pre-operative radiotherapy if you don't know whether you would need any radiotherapy after surgery. So if you have a good shrinkage, if you have perfect margins, you may not need any radiotherapy at all. And the best argument in these patients not to do pre-operative something was the case you just showed with the secondary osteosarcoma. Because, I mean, radiotherapy is also not, it's also a dangerous treatment, right? With late effects, and so you need absolutely very good arguments to do this in these young patients that we have in these units.
Do you mean pre-operative treatment?
We don't.
No. Okay.
I mean, yeah,
Sorry.
I wouldn't say
Okay.
that we never
Yeah.
do that,
No,
but
yeah.
It's country and site specific.
Yes,
I know
I know.
some sites in Europe they love to do
Yeah.
pre-operative radiotherapy, but
I have to say, in a preoperative setting, in arms or in retroperitoneal tumor, we know there are some results, and because in the radiotherapy after surgery can give more side effects. But in head and neck, I completely agree. Do not do radiotherapy before surgery. Absolutely. Yeah.
If I can add something, there are some clinical situations where you can use exclusive radiotherapy. So chemo and exclusive radiotherapy, and that is the case to go for protons probably, like spine and like sacrum. In all the other situations, better, especially in children. So the tendency is to use chemotherapy and surgery when you are confident to obtain adequate surgical margins. In those cases which are a little bit extended and you are not sure to obtain surgical margins, so in that cases you can go for preoperative radiation and then surgery. If not, surgery first,